And then just a logistical thing. Great. So Anne or Govinda, you're recording the meeting, is that right?
Correct. Yeah.
Yeah, because what we're planning on doing is after this, sending around the recording and the slides and some other resources to people. So particularly if people haven't been able to make it or couldn't stay for the whole thing, we can share that. Right, I am going to get started. I think people will join as they can. I've got to say, I'm really pleased that we've been able to put on an event, even though we couldn't do it face to face, which was a shame, that we've been able to adapt and put on something. So a shortened version of what we were going to do, but hopefully just as entertaining and potentially more focused and accessible. So I'm really glad that so many of you could join us. The agenda that we've got for today is I think, a really exciting agenda. For me, during the transition to a new health system structure like we are going through, it's really important to remember and celebrate what we've done so that we can carry that forward into the new world, as well as thinking about how we might need to think and work differently in the future. So that's why we've structured the agenda as we have. I'm going to do an introduction, talk a little bit about what we've achieved through clinical leadership in South West London thus far and what we might need to focus on and do differently going forward. Then we're going to hear from the Dermatology Network, who are going to just talk about some of the fantastic things they've been able to do in the last couple of years. And then we will hear from Sir Muir Gray, a bit of thought leadership around what we need to do as systems to create better value in health, and also to talk about health longevity. And then we will just have some reflections at the end. There's so many people on the call. I'm going to ask that people don't put their hands up during presentations or try and ask questions. What we will do at the end of the dermatology section, we've got a bit of time for questions and answers, so we can use that to ask questions about dermatology or more generally. And then after Muir has spoken, we've again got some time just to do a bit of question and answer and reflection time. So if you've got things you want to feed in, please feel free to use the chat function, assuming that is active. And what I will do is I will just keep an eye on that, and I'll compare the question and answer session. If there are themes that come up in the chat, I'll try and make sure we cover those as well. So I hope that some of you, if not all, have had a chance to view the 5-minute video of the 2019 clinical conference. I was quite moved looking back at it, actually. I thought it was a brilliant video. And it was just such an important milestone in our journey. I think we formed good relationships. We built on relationships and strengthened relationships, and we set some ambitions for what we wanted to achieve. And for me, that formed the bedrock of what we were then able to do during COVID, because we'd established those relationships and principles, priorities and ambitions. It gave us a really good starting point that when COVID hit, we were in a good position to work together to get through that. For me, today marks the end of 5 years of chairing the South West London Clinical Senate. So I'm glad we're able to do an event, because I just wanted to say thank you, a real heartfelt thanks to every one of you for the support that you've given me, and also all that you've done for patients in South West London over the last few years. Prior to this, we asked you to send in some of the achievements you're most proud of as clinical networks and transformation programs, and we've started to capture those. We were going to present them at the face-to-face event. What we've done instead is we've pulled them into a PDF pack, which we will send round after this. Some of them aren't complete. We're still waiting for the communication and engagement team to check that back with people. So it will be built on over time, but I'll send it out afterwards. I have had a look through, and what people have been doing is just remarkable, what you've been able to achieve as you work together. So this is just an example. This was the slide, the page from the Maternity and Neonatal Network. This one is the Neurosciences Network. So this is what they look like in the pack. I pulled out the neurosciences one because they've chosen, we didn't tell you what to talk about, they've chosen to focus on the Neuro Voices network that they set up, which is a way of giving patients a voice in the delivery of neurosciences, and engage patients with shaping how services need to look for the future to meet their needs. And I just think it's a brilliant example. There's so much innovative stuff in the pack. It was really exciting to read. So I'm about to start a 2-month sabbatical at the end of next week. One of the first things that I'm going to be doing is attempting to complete the Paddy Buckley round in North Wales. So that is a 67-mile adventure across 47 peaks in Snowdonia in 24 hours. You might think that's silly, but back in 2019, I did the slightly more iconic Bob Graham round in the Lake District, which is slightly shorter, but I have to say equally challenging. So you might be thinking, how did you do that? More importantly, you're probably questioning, well, why would you do that? And I imagine some of you are also wondering, well, how is this relevant to the clinical Senate? Well, there are three things that I learned through doing a challenge like that I think do apply to what we have to do as leaders in the NHS. 3 Ps, I'll call it: preparation, perseverance, and people. And I just want to make some simple points about these 3 Ps. I do think they're quite simple, but I think also they're quite profound. And sometimes the most important things are actually quite simple if we remember them. Before I go on to that, I will just go back to the why. So why did I do this? Well, it was actually all about Josh, who you can see in the photo. Josh is 15 years younger than me, and I would say, I mean, how I met him and agreed to do this is a story for another time. But Josh is a naturally gifted fell runner, but Josh is also an alcoholic. So we were training separately. I got a message in January 2019 to say that Josh was in hospital on a drip, withdrawing from alcohol. So not a good start. From that point, we managed to pull it round and train together, and eventually we managed to do it. And this was such a watershed moment for Josh. It gave him self-confidence, gave him a sense of achievement, and actually he has totally turned his life around. He's now working, supporting alcohol and drug users with his own lived experience, and he's just been promoted to a managerial role in the service he's working in. Not touched a drop since January 2019, and obviously we're doing the Paddy Buckley round together. But you know, sometimes it's things like that motivate you, that keep you going. So 3 Ps. First is preparation. So I had to put the card in on the left. That was a card my daughter gave to me a few years ago. So you can see in my family, I've got a bit of a reputation for being well prepared for trips and events, and I do like kit. So I think she was finding a nice way to take the mick out of me. But preparation is key, and preparing for the events I've done, it's so important you get the route right. You need to know where you're going, and you need to carefully map out all the steps you need to take to get there, and getting the route right is mission critical. Also getting the right kit, the right hydration, the right food. The time spent thinking and planning is the most important bit, and I end up visualizing the event again and again, thinking about all the things that could go wrong and planning for that. So my challenge to us is, how much time do we actually spend thinking and planning effectively in the NHS? Is definitely not as much as the time we spend reacting and firefighting. And time that we take out for planning and thinking, like today, when we just have a bit of headspace, is one of the most effective things that you can do. And I would just encourage you going forward to make sure that you carve out the time for that, and we don't just keep running around trying to deal with the immediate problem in front of us. The other key bit of preparation is training. Obviously, for an event like this, you've got to get physically fit and psychologically prepare yourself. My main issue is not getting physically fit enough, because I can just make myself do that. My issue is actually overtraining and injuring myself. I think that is a problem I've encountered in work as well. It's easy to do too much and injure yourself. And actually, I see lots of injury going on around me, lots of psychological injury. And the first sign of that is being less effective and productive. One of the best things my coach ever said to me was, make sure you sharpen the axe. So I said, what do you mean by that? And she said, well, if you're bashing away at a tree with a blunt axe, it will take you a very long time to chop it down, and you might not manage it. Just take some time out to sharpen your axe and come back to the task, and you'll be much more effective. So I built that into my way of working. I have to say, it went out the window a bit during COVID, and I suspect that's the case for a lot of you. And that's partly why I got a bit burnt out and why I'm actually taking a sabbatical. But the second thing I would say to you around preparation is prepare yourselves, be kind to yourselves, pace yourself. Remember, and this is something I had to tell myself, taking time out is not slacking, and it's not letting other people down. It's making yourself more effective. The next P is perseverance. So we tried this event in June 2019, and it was the most horrendous conditions you can imagine. You could see about 5 meters in front of your face. There was heavy rain, heavy winds. I looked at my Strava feed and I could see how close we'd been to the edge of a cliff, which we just couldn't see as we walked through the dark. So that was pretty challenging, but we went back in August, the hottest bank holiday on record, and we did it. The biggest thing with an event like this is the mental challenge. You get yourself physically fit enough, but it's all about the mentality. You've got to have the goal in the back of your mind and know where you're going. But if you focus on that and you think about the task ahead of you, it becomes totally overwhelming. You've got to take it one peak at a time. You just got to focus on the task in front of you. The challenge that we're facing in the NHS, I think, seems overwhelming. We've got a backlog, there's no money, we've got a burnt out workforce. So the answer is to do the planning, to take care of ourselves, and then simply focus on what we can do right now to the best of our abilities. There has to be a plan. We have to know where we're going. We have to know we're doing the right things, but focus on the task in front of you. Don't think about the whole thing, and that is more than enough. They do say, how do you eat an elephant? Well, it's one bite at a time. So my encouragement to you is to persevere and just do the best you can, because that's more than enough. The third P is people. So you'll notice how much I spoke about Josh, because this was not a solo effort, it was a journey together. And by the way, that is Coca-Cola, not Guinness, just in case you're worried. So we were a complementary pair. When he was flagging, I encouraged him, and vice versa. And you both have ups and downs at different points in a journey like this. And we had different strengths and weaknesses and very different styles. But actually, we worked together really effectively. We also had an amazing support crew who met us in the valleys. When I was hallucinating because I was rather dehydrated and I asked for my legs, my wife knew how to take care of me and gave me a new pair of trainers. So the support you get sometimes can really make the difference. 5 years ago, I was asked to take on chairing the clinical senate. Now, I said I would only do it if I had an acute medical director to co-chair, and that was the best decision I made. So Jane Wilson co-chaired the clinical senate with me for 3 years, and then from the start of COVID, Nena Asuji took over, and we co-led clinical leadership in Southwest London for the most difficult part of COVID. I would never have been able to do that without support, and particularly without Nena and without us supporting each other. It can be very lonely in leadership, particularly at the top. So having someone to work alongside you is just so critical. Now Gloria's taken over as co-chair, and John Byrne, the new Chief Medical Officer, will join her as co-chair from the 1st of July. And I just think that is the right model. So I'm really pleased about that. But this is just an opportunity for me to say thank you to those individuals who've supported me. So thank you particularly to Jane and Nena, who never really had a leaving do because of COVID. And I think often we're not very good at saying thank you to people. So I just want to say a personal thanks to them. I also want to call out the non-clinicians who've supported us in the clinical senate and in clinical leadership more broadly. Particularly, I need to just mention Karen Broughton and Charlotte Gorn, who, as two executives, have really been incredibly supportive and helpful of the clinical senate and leadership more broadly. And that clinical conference in 2019 would not have happened without either of them. Now, they're the big names, but I also want to just mention Jewel, who's now moved to Merton, who supported us in the clinical leadership group and Senate through COVID, and Govinda, who is on the call and working things in the background. Nothing happens without people like that. So thank you so much for everything you've done. I really, really appreciate it. So talking about people and working together, that I think is the beauty of our clinical transformation programs and our clinical networks. They've been designed with that principle in mind. We've got lead pairs from primary and secondary care in our elective networks, and that just reflects how we've structured things from the Senate. So again, my exhortation to you going forward is don't forget that principle. Don't work alone, and remember the joint working between clinicians and managers is mission critical. So just finally, for me, watching our clinical networks in Southwest London develop has been one of the most exciting things to see in my career, to be honest. I've just got to say the chief execs in Southwest London have been really supportive of this, and James Marsh had really stepped up to be SRO for the clinical network. So I've just got to again say thank you to him for all that he did. We took clinicians from different hospitals who were very much focused on their own waiting lists and their own way of doing things. And we brought them together in a network to think together about all the patients on the waiting list, who had the greatest priority, and how you could standardize the approach to get the best outcomes for patients. I think that was brilliant. From the beginning, we put primary care leads in alongside secondary care so that we thought about the end-to-end pathway. What happened to patients before they ended up on hospital waiting lists, and what happened to them after they'd had their procedure? That sounds really obvious and straightforward to us. It isn't, and it's become the model for how London has set up their clinical networks as well. So much so that when they went out for an anaesthetics network, they sent out an advert for a GP lead for the anaesthetics network. I did say, well, hang on, we set a principle here, but there was something behind the principle, which is you're a key part of the pathway. I didn't quite get that one, but it showed how much that principle has resonated with people. You're going to hear some amazing stuff from the Dermatology Network about what they've achieved and what's possible through this approach, about how they're thinking not just about patients with skin problems on waiting lists, but those who have difficulty accessing services and those who aren't on waiting lists. Now, that for me is the key challenge for all our networks and transformation programs going forward, to start thinking about the whole population with a population health management approach, not just those who arrive at the doors of our services. And you will hear from Samir Gray after the Dermatology Network a bit about what that means and how to ensure that what we do really adds value and meets needs. So just to sum up, I'm really excited about the potential in South West London. I think we've got the right culture of how we work together. I think we've put in place some of the right structures. I can't wait to see what can be achieved over the next few years if we really start to think and behave differently. And today is just another opportunity to challenge ourselves to do just that. So I will stop there and I will hand over to the Dermatology Network.
Thank you, Andrew, and just thank you to you and all the senior leadership for championing the networks. I think it's brilliant. And on a personal note, thank you for the mentoring that you provided over the years. I think I've been bothering Andrew since I was a registrar for the next clinical leadership role that there could be, and Andrew's always provided that support. So thank you for that. And it was through his support that I was recently appointed as NHSE London Primary Care Lead for Dermatology because of the encouragement he provided. So thank you. So we're going to talk about dermatology and the Dermatology Network and everything that we've done over the past couple of years. I wonder if Govinda, you could pull up the slides that are there. So I'm Aditi Shah. I'm a GP in Merton and South West London Dermatology Network co-lead. I asked my co-leads what they wanted to tell you about our network. And the first thing they said was about how amazing it is in terms of collaboration, the culture and inclusivity. And the collaboration has come because we've collaborated with clinicians, managers, and senior leadership right across South West London in order to achieve things for our patients. And the culture has been because we have changed the culture. There's been a shift from working in silos to working together, for clinicians and managers to work together, working with patients in a completely different way, making sure that everything we do reflects on the patient journey and what they want to achieve in terms of their healthcare. And inclusivity in so many different ways. We're so proud of our network because we have a multidisciplinary team. Initially, it was myself, Dr. Victoria Akras, as a consultant dermatologist, and myself as a GP, as co-leads. And then we had Julia Sue, and really importantly, we had Alberto Barrera as nurse consultant. And so we have a diverse range of experience, which helps in terms of the leadership that we provide. Next slide, please. And you can see the vast number of people that we've engaged with. You can see that we've been inclusive in terms of using medical students, dermatology registrars, trust clinicians, managers, externally, the British Association of Dermatology, GERFT, the list goes on. And this is probably not all the people we've engaged with. It's been a brilliant collaboration of so many different talents and people identifying things they're good at, and we've let them run with that. So I'll be talking a little bit later with you about some of the things that some of the dermatology registrars have done, and also some of the visions that some of the other consultants have had, and how we want the support of the Senate for those. Next slide, please. I'll tell you a little bit about our key achievements first of all. Some of you might have been here for the last Senate in September when I last presented, and we mentioned about the money that we had been awarded from NHSX. We'd been awarded just over £380,000 for teledermatology. And since then, things have progressed. So primary care, the PCNs, 44 PCNs now have the mobile phones and the devices, the either the demoscopic toolkit, or they're taking images of inflammatory skin conditions via the phones. And we've also developed a set of multilingual patient education videos, which I'll talk about a little bit later. We've also identified training and education for clinicians in terms of dermoscopy and skin of colour training. We're also really proud of the fact that we've been awarded £296,000 by RMP in terms of modelling what Chelsea and Westminster have done, which is basically to have a medical photographer sitting within an acute trust, and then that being a triage point where photos of lesions can be taken. And at the moment, we're still trying to identify which trust in South West London will be the first trust to do that. And that's a key point in terms of mirroring what's happening in other ICSs across the region. And I mentioned about working with a wide range of stakeholders. So dermatology was one of the first ones to be involved in the joint formulary. And so we had pharmacists, dermatologists, primary care, other clinicians and members of staff who were involved in producing the joint formulary for South West London. So whether you're a patient in Merton or Richmond, or going to Kingston Hospital or Croydon Hospital, everybody can access this joint formulary, making sure that there's equitable access to these medications, and also that there's some sort of uniformity in terms of the medications that you're prescribed. I'll talk a little bit more about the skin of colour training shortly, but also just to remind you that we've got a universal set of guidelines for common skin conditions such as acne, eczema, psoriasis, hyperhidrosis, and it's really important that in terms of our care to patients, that we as GPs and those in the community try to follow those guidelines. But also when we seek advice from our consultant colleagues, they're starting to reply by appending those guidelines to the replies. So there's a constant training and education process as well. Next slide, please. And so I'll tell you about teledermatology and the journey so far. So at the heart of everything we've done, we've made sure that patients are key. And the first thing we did was to do some focus groups with patients across South West London. We asked them about what they wanted us to do with the money that we were awarded. We did semi-structured interviews, but we also just got feedback from the patients that we were seeing day to day and asking and knowing from their feedback what they wanted. And from that, and from the feedback from clinicians, they suggested that what they wanted was to know how to take good photos of their own skin so that they could be submitted to healthcare professionals. But where could they find reliable sources of information about their skin? There are so many different sources, and sometimes Dr. Google doesn't always have the correct answers. And how do you empower clinicians to diagnose skin conditions in different skin types? So we have a diverse population across South West London, and with that means that sometimes skin conditions can present differently. And sometimes that meant a delayed diagnosis for those patients. So patients were really keen to ensure that our clinicians felt more empowered to diagnose skin conditions in different skin types. Next slide, please. And so, on a warm, sunny day last June, we converted one of the consultation rooms in the Nelson Medical Practice into a TV studio, and we filmed a set of multilingual videos. We took the most commonly spoken videos, commonly spoken languages in South West London, and made the videos according to that in English, Gujarati, Tamil, Urdu, Polish, BSL. And we made sure that they were demonstrating to patients how to take good quality photos of their skin. Next slide, please. So here you have Dr. Samantha Keegan, who's a consultant at St George's Hospital. She filmed the one in English about how to take good quality photos of your skin. And it was her hands that we used as a model in terms of demonstrating how to use the camera. These videos were recognised by other ICSs such as South East London, but also by NHS England as well, in terms of their diversity and the fact that we've not just left them in English, but we've addressed the local population and the different languages that we speak. Next slide, please. I'm sure you all recognise Vasa here. He did the Tamil version. And again, reflecting the diversity. I'm getting a little bit of an echo. I don't know if anybody else is. We might need to get somebody to be on mute. Next slide, please. One of the requests from the patients was to do common skin condition videos. And so we did various skin conditions, pediatric eczema, psoriasis, skin cancer, and so on. And actually, these videos have been extremely successful. And for example, the lymph node examination video, which is by one of the dermatology nurses, has received 1,000 hits to date. And this is where we need your help. Wouldn't it be brilliant if a patient who has been to a skin cancer clinic could have a QR code on their letter, no matter which trust they went to in South West London, and they could zap that code and access that video that Linda has recorded for lymph node examination. Or, for example, we're working on patient-initiated follow-up for pediatric eczema. Again, they could have a link via the patient portal or the QR codes so that they could access the pediatric eczema videos. And so they could access the videos, they could go to group sessions, and that would reduce the number of follow-ups that patients would have to have. It would mean that they don't have to travel unnecessarily to the hospital, but it would also empower patients to be in control of their own health and how they access healthcare. And so I ask all of you here, representing your individual trusts, but also the general practice as well, how can we promote these more? How do we universally have these QR codes across South West London, so wherever you are, you can access that video? How do we make sure that when we're seeing our patient in general practice, that we can signpost patients to these videos? They're already on the trust websites, they're on the Acute Provider Collaborative website, but I think we can go further with this. Next slide. And next slide, please. I mentioned earlier how patients in South West London had mentioned about sometimes having a delayed diagnosis because of their skin condition, because of their skin type. And certainly those with skin of colour had said that sometimes their skin condition presents differently, and therefore sometimes clinicians weren't always sure of the diagnosis. And so we're really lucky in South West London to have had Dr. Marissa Taylor, who's one of the lead consultants in terms of skin of colour training, deliver a talk to primary care about viral, bacterial and fungal infections in skin of colour. But also we looked at wider at all the different people as part of our network. And I'm really pleased to introduce Emma, who's one of our dermatology registrars, who was inspired to produce the Afro-textured hair training as a result of her experience. Emma?
Hello everyone, I hope you can hear me. Great, thank you. And thanks for the introduction, Aditi. Yes, this was stemmed out of an informal conversation I overheard within the registrar's office, where they were saying that it's often a bit of a heart sink when they see patients with Afro-textured hair in clinic, because they're really not sure, exactly how to go about it and understanding all the different things that we do to our hair. So I led a teaching session just locally in the department, and later I was asked by Dr. Akras to create this information leaflet, which Dr. Akras is really supportive in helping me do. And then she invited me to give the training to the South West London network. So it's definitely a huge privilege and an honour to be able to speak to other dermatologists and GPs in this way, and to educate on this area that seems to be slightly neglected over time. So I'm really happy to have been able to have the opportunity to do that.
Thank you, Emma. And if people want to access that leaflet, it's on the St George's website. But again, we would welcome suggestions about how we promote this further, because we're so lucky to have people who have the vision to share these things with us. And I have to say, I learned so much from this. It was something I just didn't know anything about. And yet it's so obvious when you receive the training that it's something we should all know about, especially as general practitioners and the patients that we see. So thank you, Emma, for that. And we've talked about all the positive things about the networks, but of course there have been challenges. Some of those have been around just the amount of work there is to do, because we're so excited and we want to achieve so much. But also we've had quite a lot of change. There's been a lot of change in managers and people moved elsewhere. And I think the one thing I'd really want to see with these networks is we really solidify them and make sure that those talented managers that we recruit, that we retain them, because they are such a vital part of these networks. It's a collaborative process between all of us, and it's the strength of the managers and the senior leadership and the clinicians together that have really driven these networks forward. And that's what we're thinking about next. What could we do as a network that isn't just about the metrics, because we do think about the metrics all the time. We regularly meet with the managers across South West London and think about how we tackle that backlog. But there is the other side, the much more holistic side of dermatology that is so important and sometimes we forget about, but it is so important for the patient and what they believe. So I'm going to ask Dr. Bernard Ho, who is a locum consultant at St George's Hospital, to talk about his pilot and to see how the Clinical Senate can really help drive this forward. Bernard?
Thank you so much, Aditi, for letting me come to the Clinical Senate today. So, hello, I'm Bernard. I'm one of the locum consultant dermatologists based at St George's Hospital. And I started a pilot local skin and mind clinic here at St George's Hospital in March 2022 in response to the GIRF Dermatology and Southwest London GIRF reports. We know our local patients don't have an easy access to a dedicated psychodermatology service, and they currently have to travel to East London for their care. The future goal for this service will evolve to include not only a consultant dermatologist and a consultant psychiatrist, but also a dedicated psychologist and a dedicated social prescriber with established links within the community. We hope with the support of Clinical Senate, we can shape the model of the clinic with holistic working with other stakeholders, such as the community and acute mental health trusts. We also want help with the financial stability of the pilot and service in order to improve the inequity of access currently to the service. Thank you.
And I know Bernard is really keen to speak to all of you who are involved in the mental health services, social prescribing, to really make this a holistic model. And so I'm sure we'd be happy to take some questions afterwards around that. And finally, I wanted to talk to you about nurse training. Last time when we met at Clinical Senate and we talked about dermatology, Alberto Barrera shared his vision about nurse training. Alberto is currently in Italy, but I know he's really keen to update you on what we've achieved so far. There's a recognition of what South West London is doing, and his vision in particular, about making sure that we retain nurses and train them. Because of our location, historically, we've sometimes lost dermatology nurses to, for example, St John's, once we've trained them up. And so what we really need to do is to provide and support training for the nurses so that they can get skilled up and then provide extra support to the workforce. There are so many things that our dermatology nurses can do, from phototherapy clinics to allergy clinics to eczema follow-up to group sessions, and they're a vital part of the workforce. And I ask all of you in each of the trusts that you work in to please support what Alberto is doing, because I think it's visionary in terms of the future of dermatology. I did mention that Alberto is not here, but he has recorded a video for you all, and I hope you'll agree that that you'll agree to support nursing and dermatology. And so over to Alberto. I think it's just going to take a second to load. I'm hoping the tech works, otherwise we'll put the video in the chat.
Hello, my name is Alberto Barrera. I'm a nurse consultant in dermatology at Kingston Hospital, and I'm one of the clinical co-leads for the Southwest London Dermatology Network. I'm sorry I cannot be at the Senate. However, I've recorded this short video because I have a few things to share with you. So when I joined the network, I joined a very dynamic clinical lead group that not only is inspired by innovation and patient-centered care, but also recognizes the relevance of a multidisciplinary approach to the care we want to deliver to our population. As the clinical standards are moving towards providing a more innovative and holistic model of care to our patients, partnership across different health professionals in the NHS is vital, and I'm pleased that we reflect that collaborative and multidisciplinary approach in our group. So I want to share a few things about where we are in terms of dermatology nursing care. So throughout the years, dermatological nursing has advanced to the point that skills like skin surgery, drug monitoring, skin cancer screening are now integral part of the skill set of dermatology specialist nurses. Therefore, having a structured nursing workforce has proven to relieve consultants from the pressure and allows them to focus on more complex patients. But also it contributes to providing holistic care and a patient-centered approach to patients, also to be a reassuring point of contact for them. Unfortunately, those specialist nurses, not just in dermatology, but I think have a feel in general, are in great shortage. I think this is mainly due to the lack of awareness of these specialist roles, particularly by nurse students or junior nurses. They're not aware they can become specialists. But also there's some inequality in the access to training and some sort of inconsistent career progression pathway and opportunities across different trusts. So in terms of collaboration and training, our network gave its first example of mutual support earlier on this year when a specialist nurse visited another hospital to train a junior colleague in delivering phototherapy, which is a special treatment for patients with dermatology skin conditions. So this allowed that service to finally open, and they were able to deliver phototherapy in that particular trust, thanks to the mutual support where a nurse had to go to a different trust to train a colleague. So we have now set up a subgroup aimed at supporting the dermatological nursing training in Southwest London, so that all nurses in dermatology have access to a high standard of education, and we can create a network of support amongst peers in the Southwest London region. We also aim at working closely with the British Dermatological Nursing Group to look at job role descriptors, training opportunities, and how this can be implemented to enhance recruitment and retention of highly skilled nurses. We are indeed in a very early stage, but already assessed the current situation and needs in each trust. And this revealed that each department is very different in terms of their service provision. But the need for education and progression of skills is actually very similar. So by identifying a common pathway, Southwest London could potentially become a national champion for nursing education and development in dermatology. But hopefully this model can also be transferred to other specialists. So thank you very much and have a great Senate.
Thank you everyone for listening to our presentation. We'd be pleased to answer any questions that you have, but also thank you to everybody who's championed the networks, and I hope you've enjoyed the presentation.
Wow, thank you, Aditi. That was phenomenal. I mean, what a great range of stuff you've been doing, and it's so obvious how how much you're enjoying working together as well. So really, really well done. It's just so inspiring to hear that. Shall I open it up just for a minute or two to questions? I can't take questions from everyone, but if there are one or two questions or reflections that people want to give, then I'll give people the opportunity now, but I can't promise to take all of them. I think people are stunned into silence, Aditi. Who dares follow that? Right, I'll take those two. I'll take Agnello, then Louise, then no more. Then we will go on to Muir. So Agnello.
I've only got one word.
In fact, Agnello, do you want to introduce yourself? Let's just take the opportunity. Introduce yourself, and then Louise can do the same, because it's exciting to have Louise, who's not a doctor either.
Agnello Fernandez, GP, and after next week, former borough lead for Croydon. So I've only got one word. Wow. You've really set the bar for us in terms of what a network can achieve, and it's absolutely brilliant. So well done.
Brilliant. And Louise.
Lovely. Thank you for finding me exciting. That's made my afternoon. I'm Louise. I'm one of the pharmacists, and I'm based in Croydon. And thank you for promoting the South West London formulary. That's even more exciting for me. So there was a lot of hard work that went into that, wasn't there? So so it may have been a line on a slide, but that's a huge piece of work. But I was just wondering about community pharmacists and self-care, and I wonder whether we need to have a think about bringing in some of our community pharmacy colleagues into some of these conversations around pharmacy first and so on and so forth. It was just a comment really, whether or not that might be something that we can consider going forward.
And Aditi, I'll let you answer that. I'm going to just throw one more question in, which is linked into what Jane Thorpe has said in the chat. She's mentioned the issue of workforce, and that seemed like a big thing that you were considering as a network, particularly from what Alberto said. And I'm sure that every network is grappling with that. I mean, it's surely one of the biggest problems we've got across the NHS is our workforce. So answer Louise's questions, and then is there any support you've had from South West London around workforce, and if not, what would be helpful as a network, and what could you feed into the learning for South West London in terms of doing that better going forward?
So I think, first of all, yes, thank you. There was a huge amount of work for the joint formulary, and it's not just for dermatology. I know the other specialties are using it. So if you haven't used it, please go to the link. I'm hoping someone might be able to share it in the chat and go and have a look. It's accessible for everybody. In terms of community pharmacy, you're quite right. 75% of skin consultations happen in primary care. So why not extend this and make sure that the self-care side is part of it? But also, how do we think about transforming that even further in the future? So some of you will know that with my other role as ENT network lead, we're looking about community pharmacy and using a device called a Timber Health device, which looks at digital otoscopy, wax microsuction, and doing a hearing audiogram. And so are there similar ways that we can think for skin? Because often the first place that patients will go is their community pharmacist. And we need to think about novel ways to look at that. So we'd be really keen to engage. And if you've got any further ideas of how that could happen, we'd be really open to that. You're right, we have self-care guidance for a number of skin conditions, and maybe it's worth thinking about how we, with the comms team, promote those a little bit further, because I think sometimes they rest in one place and not everybody knows where they are, and how could patients find them more easily as well. So there's lots to think about there. In terms
and then the workforce question, sorry, just Jane put her hand up but went back down. I think I probably didn't capture her question totally. She was also asking about how do we develop staff who can work across multiple needs or conditions, not just one condition, which I think is also a good question. I'm not expecting you to answer that, Aditi, but just give a few thoughts around workforce.
Well, I might ask for some help from the dermatologist with that bit, but to answer the workforce question, and this is not just about dermatology, but we must think differently about workforce. Who do we engage, whether it be training up more nurse specialists, using our physicians associates, training up other people who could provide the service, depending on what it is. So, for example, in other areas, the teledermatology part, the photos, have been taken by a healthcare assistant? Or how could we use technology and digital innovation and AI? All of those things are really important, especially as we start to look at the teledermatology side of things, where we sort of mitigate for perhaps a reduced workforce, but work differently. And so I think this is not just about the people, but the technology that we use, and also how we work as a system as well. And I think the dermatologists are really keen to engage with those that might have ideas about that. I'll just ask if any of my consultant colleagues want to come back on that. I think there are a few dermatologists on the call at the moment.
Maybe we could pick that discussion up outside, or get them to put their further thoughts in the chat. What I don't want to do is eat too much into the next bit. I think it's a fascinating discussion. I think it will link quite beautifully into the next section, which I'm absolutely delighted that we've got Professor Muir-Gray here to talk to us, and it's almost as though we designed it, isn't it, Muir? How it's beautifully flowed together.
Firstly, let's just take a minute to stand up, shall we? I'm going to pass a law that no one should be in a Zoom for more than an hour. So let's just have a stretch for a minute, and then I'll kick off. I'm going to stand up. Good. Well, welcome back. Well, Andrew revealed he's got shorts on. I've been in Riyadh this morning, so I've got a collar and tie on. When I'm working in Riyadh or Sao Paulo or somewhere, they always expect the collar and tie, a bit like the civil service in England. But so that's why I've got the collar and tie on. So I'm going to tell you about the future. Not because I get visions get you psychiatric referral, but because the future is here, just not evenly distributed. And I'm going to show you some images. Now, let me just see if I can do this. Andrew, I'm hitting the share button.
It worked for me. There was just a bit of a lag.
Hang on. Hang on, no, that's not quite right. Because I need went back to the end again. Because I want to start with this image. And this is an image to pick up a point that Andrew made of the London Circular Road, designed in 1943 when the bombs were falling. And I said to Andrew at the weekend, I know there's pressure and the top management expect you all to be working to cope with the rail strike, but even in the middle of war, you have to find time to think ahead. And that's what we're going to do now. And I'm going to cover two issues that are part of the third healthcare revolution. The first healthcare revolution was the public health revolution of the 19th century. And there are very many famous actions took place in southwest London. And many of you will recognize the building on the left as playing a key part in the public health revolution, which gave us clean, clear water. There's a wonderful book about it, about the battles that took place and the corruption and the various other issues, but it was a revolution. The second revolution of the last 50 years is epitomized by the picture on the right. And it's interesting how hospitals have become the landmark building of the 20th century. The landmark building for many hundreds of years was the cathedral, like Southwark Cathedral. Then in the 19th century, it was the railway station, which was linked to the public health revolution. But there are no landmark buildings for the third healthcare revolution, which is driven by three forces: citizens, knowledge, and the internet. And the third revolution is based not on buildings, but on population-based systems and networks. So here, I've been in Oxford 50 years. When I first went to Oxford, I tried to find an answer to the question, is care for people with asthma better in Oxfordshire or Cambridgeshire? And I couldn't get an answer. Today, 50 years later, 20 reorganizations later, I still can't very well get an answer to that question. These are population-based questions. And don't feel paranoid in Southwest London. I could find and replace Southwest London with Liverpool or Manchester or Somerset or Edinburgh or Toronto or Rome or anywhere. We cannot answer population-based questions in spite of the excellent work being done. And I'll come back to the excellent dermatology work being done. So this is what the future looks like. Need and demand will increase faster than resources. And one thing that COVID taught us was that resources mean much more than money, because the money was unlimited, it seemed, but we had problems with staff time. That's the key resource. And I'll come back to carbon a little bit later. Now, what is the reason why need and demand is increasing? Well, population aging is usually blamed, but there are other causes. And we need to think of a new approach. And we need to recognize that in addition to the high-tech developments of the last 50 years, hip replacement and chemotherapy and transplantation, we have had a number of very important developments in management and thinking. And these developments are summarized here. Prevention, for example. The concept of effectiveness. It's 50 years since Archie Cochrane published his book, Effectiveness and Efficiency. Evidence-based medicine, we set up the Centre for Evidence-Based Medicine in Oxford about 96. And then in the last 20 years, quality and safety. So these are all necessary, but they're not sufficient. We need a new approach, and the new paradigm is focused on value. And new paradigms always embrace and unfold previous paradigms, as shown here, but this is a new paradigm. So what do we mean by this? Well, the European Union expert panel, which we were members of before that day a couple of years ago, identified 4 aspects of value. Personal value. Is this care relevant to this person's personal goals? Are we dealing with the problem that is bothering them most, as well as their diagnosis? The evidence is we're not. Secondly, allocative value, which I'll come back to. Thirdly, technical value, which is much more than efficiency, because it would mean if you took Croydon, for example, not just what's the outcomes for hip replacements, or the people who had hip replacements, but what are the outcomes for all the people with back pain in Croydon? And then social value. And some of you will be involved in anchor hospital work. So social value would be, are we really trying to recruit nursing and medical students from the housing estates of Southwest London? Are we giving priority to local businesses or just to multinationals and letting contracts? Now, when we start to look at what we've achieved, which is considerable, we see 3 big issues we need to address. And one of these is unwarranted variation, defined by great Jack Venberg as variation that can't be explained by variation in need or by explicit choice. So here's from our Atlas of Variation. And we published this really to destabilize the medical profession, which were all telling me all they needed was more resources because they were delivering high quality, effective interventions. But look at this variation in anti-dementia drugs. Here's the variation in spend in musculoskeletal. Twofold variation. And the people never knew if they were at the right or the left of that distribution curve. It's a high level right because it comes at the expense of other budgets, or is a low level right? Now, I'm going to show you what this variation reveals. And it reveals two things. First is overuse. And this is drawn by Avedis Donabadian in 1980. And Donabadian and Jack Venberg are the giants, really. So he showed that as you invest resources, say in hip replacement or cataract or blood pressure reduction, then the benefit goes up and then it flattens off, the law of diminishing returns. Unfortunately, the harm goes up in a straight line. All healthcare does harm. High quality healthcare has a little more benefit, a little bit less harm, but all healthcare does harm. So what Donabadian did was to subtract harm from benefit and produce this J-shaped curve. Now, if I were in Merton Town Hall or Kingston Hospital, I'd be asking you to turn to your neighbour and ask, where have we gone beyond the point of optimality in our population? Antibiotics, for example. So you can't have that one. So, Andrew, let's just take 20 seconds for people to reflect on their own and start putting in the chat room, where has healthcare gone beyond the point of optimality? It may be high quality, it may be an effective intervention, but it's gone beyond the point of optimality. Okay, 20 seconds to start typing. Because we're here dealing with waste. And waste is the use of resources which will give greater value if used on another intervention for that group segment of the population or used for another segment of the population. Now, this also applies to individual patients. The population value and personal value are two sides of one coin, because as you put more resource into a population, you start treating people who are less severely affected. For them, the benefit is less, but the probability and size of harm is the same. And you can see the clinical language there is similar to the economic language, the commissioner language. So we talk about higher value, lower value, zero value, and negative value from a population approach, whereas clinicians talk about necessary, appropriate, inappropriate, and futile. And that's where the Venberg, that's where the Donabadian curve, how it relates. The population value and personal value are two sides of the one coin. Now, we also know, if we look at unwanted variation, that there's considerable variation in referral. So the people receiving a specialist service are not necessarily those who benefit most from the specialist service. Now, I was very impressed by the work done by the Dermatology Network, and I met them briefly on Monday, and they recognize this. They recognize that unwanted variation demonstrates both overuse and underuse. And underuse is often complicated and compounded by inequity. And this is a study done in Yorkshire. And you can see here, people from the least deprived part of Yorkshire, of the population in Yorkshire, got about 4 times as many hip replacements and knee replacements as people from the least deprived. This is not including private practice and insurance-funded hip replacement. And of course, we're seeing this every time we look for it. And congratulations to Dermatology for tackling it. They use the word inequity. So let's think a little bit about the future, the third healthcare revolution, systems and networks. So here's the new agenda. And here's what we've been working on with CLCH and Southwest London, and I very much hope we'll be working with the new ICS. And I should say I'm fully in favour of this reorganisation. I've had 20 reorganisations in my lifetime, most of which have made no difference at all. There have been 3 significant reorganisations. One was 1948, when I was 4. The second was 1990, when the market was introduced. And the third one now, when we're doing away with the market and talking about systems, partnerships, and networks. But I'll come back to that. So here's the new agenda. Firstly, we need to think of how this relates to dermatology. So I'm seeing, if I had power, I'd want a skincare group for Southwest London. I'd give them the whole budget. I'd give them a commitment to reduce waste and inequity. And they need to develop a single system. And I'll come back to that. And I'd like in each hospital, 1 dermatologist to be given time for population dermatology. And she would have a map on the wall. And that map would indicate the areas of deprivation and the referral rates from the different groups, together with a publication of an annual report. And as we heard excellently from dermatology, that report would have to be in a number of languages. And we are doing this with type 2 diabetes. I'm working on type 2 diabetes with CLCH, and I hope with ICS, that we need to think of people who speak Tamil and Gujarati. And as I understand it, some of the older women in those populations not only can't read English, they can't read Tamil. So let's just think a little bit about this. So here's the world as it is at the moment, really in every health service in the world. 2D healthcare. Self-care, informal care, primary, secondary, tertiary, and then a range of bureaucracies, both public and private. So what we're doing is moving to 3D healthcare. And this is a bit similar. If you were all working for Tesco, you wouldn't be thinking about big Tesco's and small Tesco's. A small team would be doing that. You'd be thinking about meat, fish, vegetables. These are the eternal verities. So this is the service lines. It may be a condition like the last year of life. It may be a symptom like back pain, or it may be a diagnosis like asthma. 3D healthcare. Now, bureaucracies are very important for linear tasks, but this is complexity. So when I looked at the data I could find, and of course, I'm not familiar with all the data, but this is what I could find. I could find £15 million a year being spent on skin disease through commissioning. But you have to, I tried to relate this to the populations, but these are borough populations. So is the borough of Croydon the same as the population served by Croydon Hospital? Probably it's close, but not exact. And what we're seeing now is the development of population-based healthcare. And certainly outside London, that's largely determined by the way the buses run. And in London, it was determined by the way the railways ran. Southwest, Northwest, North Central, Northeast, and Southeast. These were developed in the 1948 on the basis of blitz clearing lines, the way the railways ran. Very sensible, actually, long before the car became common. So I'm interested in, well, how many populations are there? And we've heard, I think there are 4. They're all Marsden's a bit odd, but that's tertiary care probably. But we need to know their total population and the amount of money being spent by the population. And that would include GP prescribing as well, which is probably, I would guess, closer to 30 million. Now, this is part of the problem of allocative value, how we divide resources in between different populations. And this is using something called Bridges to Health, which is better than the International Classification of Disease because it allows for multi-morbidity. So this lets us look at this sort of picture here. And then we could ask, well, how much do we spend on mental health? Just ask you all to think for a minute. Write a number down. Probably about 12 billion. And the next level is this. And the next level is this. allocative value. Secondly, we develop a system for each subsegment. Here's the work we're doing in diabetes. And when we worked on objectives, these were the objectives that came up. And I said, very good, 5 out of 10. Just think for 15 seconds about another objective you might add on to that list. Remember, this is a clinical group, a clinician group with patient involvement. Specific responsibility for the optimal use of resources, specific responsibility for minimizing the effects of deprivation. Then we need to personalize, step 3, and step 4, develop networks. And that phrase was very well used. This is the century of the system and the network, which float beside the bureaucracies. It's not a new bureaucracy, it's a new type of organization. And finally, this key issue of the culture of stewardship. And as one of my heroes, Elinor Ostrom, who got the Nobel Prize in 2009, she said there's no point in privatizing common resources or sending government in. The people who use those resources need to become the stewards of the resource. Now, this means a new set of skills, and I'd very much like to work on this with the ICS. These are the sort of skills we've been working on, and we're working in a number of countries. New ways of thinking. It's new language. We don't need new bureaucratic powers or structures. We need a new paradigm, value-based healthcare. And just the last point is this paradigm will, of course, be overtaken by the new paradigm, which is low carbon healthcare. Now, what I've done is, Andrew, and maybe take your reflection on this for a minute. So I've looked at one theme of the new paradigm of the third healthcare revolution, which is systems and networks to develop value-based healthcare for both populations and individuals. And all of this requires digital. You couldn't do it without this, the internet. The second issue I want to talk about is the work we've been doing in Merton and Sutton on developing living longer better and activity therapy. So this is the second part. So I'm shifting now, Andrew, to look much more at the individual and personal health. Any comment you'd like to make, Andrew, so far? Are people writing any examples of overuse in the
there were lots of examples of overuse, and I think you've stimulated a lot of thought and discussion. I think people are realizing as well now how much of the population health management roadmap in terms of the thinking and culture and behavior and diagrams I've stolen from you. So but for me what you're describing is population health management.
Yeah, sure.
And I think the fact that we've already got functional clinical networks set up puts us in a really good position to take it to the sort of level that you're describing. So I think it's really exciting, actually, being challenged to think ambitiously about what we can achieve.
Yeah, well, I'm hoping Southwest London could be the laboratory, and then we can spread laterally. Revolutions are often best managed by lateral spread, rather than going to the top of the office and expecting the top of the office to do it. So let's focus now on the second aspect, which is healthcare is what you do for yourself. So apart from a hospital admission, if you're a long-term health problem, you're on your own 99% of waking hours. They're very important, primary, secondary, and tertiary care, but healthcare is what you do for yourself, supported by friends and family, and we deliver professional health services. That's very clear. So I'm now going to just give a few minutes as though I was in a bridge club in Richmond, or a bowls club in Croydon, or a mosque in Wandsworth. And I'm just going to tell you a little bit about the fact of life, the birds and the bees 2.0. And I'm speaking now mostly to people aged 50 plus. So aging is not a cause of major problems until the 90s. It does affect your maximum level of ability, and it reduces your resilience. So there you can see the impact of lockdown, loss of resilience. But there are 3 other processes taking place, the first of which is loss of fitness. And it also reduces maximum ability and resilience as lockdown showed us. And you can see it's very similar to aging, which is why the medical profession has confused these 2 processes for many years. So there's a loss of maximum level of ability, maximum pulse rate, maximum cardiac output, and loss of resilience. If I asked you all to go and run a mile, and Andrew would come back first after 67 miles, but I would know your level of fitness by your rate of recovery. The good news is that we can close the fitness gap at any age. The next problem that affects us is disease. Mostly preventable, mostly the result of the modern environment. Car, computer, and desktop. I don't call them lifestyle diseases. I call them environmental diseases. So you need a bit of luck to avoid the diseases we can't prevent. But the fitness gap gets wider faster after the onset of disease, principally because of the attitudes of other people who do things for you with the best of intentions. It's called care, a word I'm trying to ban. So you can see here a condition I've not yet got adopted by the International Classification of Disease called the line. The line. And this is the level of ability required to get to the toilet in time. And once you drop below the line, that's it, game over. People, ladies and gentlemen, you may think that if you don't really think about health, you'll pop off with a nice little heart attack. Well, as we say in Glasgow, listen, sunshine, that's not the way things happen. You'll probably finish up in a chair, unable to get to the toilet in time, and a bloody nuisance to your nearest and dearest. The good news is, ladies and gentlemen, no matter how old you are, no matter how many long-term conditions you've got, we can close the fitness gap and keep you above the line. So the third factor, loss of fitness, disease complicated by cellular loss of fitness. The third factor is negative thinking, ageism, and of course, deprivation and housing problems. These are social and environmental causes that we've often assumed are due to aging. So that's what is happening to us. That's what we need to do. Now, let me move from the Bridge Club, the Bowls Club, and the mosque to a health centre or a hospital or the town hall or a committee room. And ladies and gentlemen, the third healthcare revolution is based on systems and networks with personalisation. And we've developed something called the Living Longer Better program, and it's got 3 aims. The first is to increase activity, physical, cognitive, and emotional. I'm banning the word physical activity. I said this to the physical activity professionals. Look, you're underselling yourself. Every time I see people in a group, in a village hall or wherever, they're all smiling. It's physical, cognitive, and emotional activity. And you can see here some of the benefits that result from that. And this is relevant to people with long-term conditions, as I'll come back to discuss, as well as preventing long-term conditions. The second aim is to compress the period of morbidity at the end of life. It's not living longer better. It's not living longer that people want. It's living longer better. People are not really interested in living to 118 or 142 or the other things that the biologists are promising from laboratories. And I don't see how society could cope with everyone living to 120 anyway. But it's living longer better. And this, our third aim, is to reduce the need for health and social care. Partly because we can keep them above the line, partly because much of the acute problems that occur in the health service are due to loss of fitness. The chest infection in someone who's lost fitness tips the balance, and they get referred with a chest infection to Kingston Hospital, because the GP doesn't want to just use the word off legs, but they've gone off legs because of a chest infection combined with loss of fitness. They've lost resilience. So how are we going to do this? Well, we need a system. This is the century of the system and the network. And we're working already with TLCH, but I'd like to sign the ICS up to this system, an integrated system with these objectives. And they all interact, of course. And you can see the one at the foot of the list there. There's a very interesting one, because really what I'd like would be every bridge club, a bowls club, mosque and church group to discuss that one once a year as well. We've got to get this talked about to enable people to die well as to live well. Again, the system is delivered by networks. Probably borough-based networks would be the right level within the Southwest, but I have no strong views on this. When delivering a system objectives, you take into account local history, geography, and politics. So that's to be decided with a place-based partnership debate that's taking place at the moment. Now, the system gives leadership. And the job of leaders is to create culture. We need a cultural revolution to create a culture of enablement and coaching rather than a culture of care. And we're going to do this. We have a new language using the word enablement, only using the word aging when dealing with the normal biological process. We have a learning program for older people that we'll deliver through GP information systems and those who support them. And I recommend about 1,000 people in Southwest London whose brains need rewiring: pharmacy assistants, wardens of shelter housing, care home staff, volunteers, and of course the medical profession. But they're the most difficult to reach because they think they know what is happening after the age of 60. And of course, we've got to remember deprivation and inclusion. But I remember 50 years ago when people talked about the difficulty of getting older people to use the telephone. So this is changing fast. And here's the learning program. And we're also be developing more. These are just about 12-minute modules. And there are different briefing notes for both professionals and older people and assignments. And we're doing one or two more now on reducing your risk of dementia. We've just published a new book on how to increase your brain ability and reduce your risk of dementia. So we now need to think, everyone needs reconditioning after COVID. We want to shift the whole population curve. There's a subgroup of the population looked after, supported by aging well, which is very important. And they're the ones at highest risk of things going wrong. But with the concept of activity therapy, we're seeing that everyone with a long-term condition needs an activity prescription to supplement NHS rehabilitation and exercise medicine. There'll never be enough physiotherapists to see everybody who would benefit. We need to think in a different way. And this is called activity therapy. And it's delivered by people qualified as physical trainers, sports scientists, or exercise physiologists. They're very well educated, both in physiology and in understanding how to coach someone. Coaching's closing the gap between performance and potential. That's the same as rehabilitation, really. So starting, how do we bring healthcare, how do we bring them back into healthcare? Florence Nightingale started physical training in 1860. She was so horrified by the health of the soldiers in Crimea, but we've let them all drift to the fitness industry. Now, we also need to think how we use GP information systems. And this is the activity prescription. So here, this is a picture of all the leaflets I've had about my heart disease. I'd stent 10 years ago. So the milk bottles there, just to give you an idea of scale. So these are the leaflets I've had in the last year. And I'm very grateful for the evidence-based drugs that I'm taking. And I take, and my compliance is very good. And I take them all. The next picture will show you the amount of information I've had about activity from the health service in the last 10 years. No, don't keep looking for something. That's it. Not a single bloody word. I got very good care for 3 months after my myocardial infarction, went to the local gym, but since then, be that, not that. Now, we've been working in Southwest London, and I pay full tribute to Wideway Health Centre. I don't know if there's anyone here from Wideway. I love Wideway Health Centre. I've never been, but Cy and Dawn and all the people there. And this is called the WISH system, and Alan Naismith is here, who developed WISH. We've got approval from NHS Direct, and this is what we can now do. Alan can now do. And the GP, Andrew, you wouldn't even need to remember to press the button. We can do all this, because if you could say, look, you're going to get an activity prescription is really, really important, that would be great, but that's all we want from you. And we can deliver this. And you don't have time to read this, but this is the sort of thing. All right, there's far too many words there, but maybe the GP knows that I've got a degree, so I don't mind lots of boring words. But you can see there, this is an activity prescription. It tells me whether there's local facilities available. It gives me links to online exercise programs. And most important of all, perhaps, it gets me involved with a group of other people with the same problems. And that's part of informal care. Remember, the 99% of time we spend on our own. Other people with type 2 diabetes are there to help you with your glucose meter or other problems 24/7. So we're bringing together data about physical activity, about healthcare, and start to think how we relate to this. And we need to think a little bit about resources. And as you can see, this is the report, good for you, good for us, good for everybody. And one of the reasons for overprescribing, and Keith Ridge, the wonderful Keith Ridge's estimate is that 10% of all prescribing is pointless. That's about $1 billion a year. And here's some of the quotes from the report. At least 10%. So we need to give more alternatives to medicine, such as physical and social activities. So you can see I was also recommended in my my activity prescription to the Summertown Choral Society, because I've got a bit of lung disease from my childhood in Glasgow before the Clean Air Act. And choral singing is very good. And the GP doesn't know if I'm a good singer or not, but he wants me to know that joining a choral society is at least as important as taking medicines regularly. So what we're planning is a national activity therapy service, and this will be a network, and most of the delivery will be by people currently working in fitness centres, and I don't like the word leisure centres. I want to ban the word leisure too. Fitness and well-being centres and independent trainers. And we have to find a way of shifting some resources from the drug budget to an activity budget. So I'm looking for primary care networks who would like to work with us on that. Because, to finish on this, the gap can be closed no matter how many conditions you've got or no matter what age you are. Andrew, that's enough from me, and it still leaves us with a few minutes. So, and then we'll circulate these to any interest.
Yeah, thank you so much, Murat. It would be good to circulate, and there's so much food for thought there. I think almost every slide that you brought up was enough for a big discussion and would have got people's minds racing. I don't expect people to come away from today with a clear plan of what they have to do next. What I'm hoping...
I know where you live. I know where you live.
I'm hoping that it will have triggered some thinking and will have stretched us thinking about what is possible and what we need to be doing to make a real difference to our patients. So my challenge for the networks is, well, look, we've already got networks set up. So how do we use that infrastructure to start to shift some of this stuff? How do we use our networks to start to think about the population that we're responsible for, not just the patients who are on the waiting lists of our services? How do we use our networks to think about the needs of all the people with a condition, be that children, young people or older people. So how do we start to think about those different subsections of our population and tailor not just services, but the approaches to improving their well-being? And how do we do that with patients themselves? I think the other thing that you've heard through all the different talks is the issue of inequity. So for me, when you start to think about the whole population, you're implicitly starting to think about those who aren't getting what they need from our services, and that's a massive call to action. And I'm sure Gloria will pick that up in her closing remarks as well. Maybe got time for one or two questions or comments, and then I'm going to hand over to Gloria and John, because this is an opportunity to formally hand over really the co-chairing of the Senate to John and Gloria, who'll be taking it on going forward. So maybe one or two questions, and then I'll come to you both to give us some closing thoughts about what next, really.
There's Mo Secker making comments about social prescribing, and we are going to circulate. We've got glossary, so glossaries with definitions of words like quality and value. They'll be coming around to you all. Get the language is more important than numbers in bringing about transformation and creating a new reality.
So there's loads of questions in the chat. I think we could probably, I don't know if there's any of those you want to address now, Muir. Do you have a preferred definition of quality, and how does that fit in with the language of value?
Yeah, quality is the quality of a service is the degree to which it conforms to preset standards of goodness. So we're clear what's good and what's not good. Value is determined by the outcomes related to the resources used compared to the other use of outcomes. So you could have a very high quality service that is of very low value. And if you look at laboratory testing, which has increased fourfold in the last 20 years, the laboratories are terrific. These are high quality machines producing 4 times as many lab results as they did 20 years ago. But what is the value? So quality is necessary, but not sufficient. But that's in the glossary we're pleased to circulate. John, I'd say discuss that with you in more detail if you want, but this is not my definition. This is fairly standard definition. So
what we will do is send round afterwards. So we sent round some things before. I think what we'll do after this is send round a comprehensive email that has the recording of this, the slides, the resources that you included before, Mia. I'm also going to slot in my population health roadmap, population health management roadmap, which I think actually explains a lot of this and tells you some of the things, some of the action we're going to take in South West London on that. And I'm not totally going away. I'm taking a 2-month sabbatical, but I'm going to come back to continue to provide some leadership around population health management, because I think it's so critical for the future of our health system.
I know where you live, Andrew. I know where you live, Andrew. So that's
right. Gloria, then John. Shall we go? Which way around?
Gloria first.
Yeah, ladies first. So I just want to say thank you to everyone for coming today to our Southwest London celebration of clinical achievements. And I mean, the program itself has been very impactful, and in terms of some of the presentation, the dermatology presentation, and also, and I'm going to come back to that, Aditi, in terms of some of the challenges you've posed to us, especially with professional leadership. But before I go into that, I just want to use this medium to thank Andrew. Again, apart from him being the leader and the clinician he is, and it's just his character and his personality, I've learned so much from you, Andrew, because I came into the system brand new, and actually you really helped me settle in. And again, really accepting that challenge of everything has to be multidisciplinary, multi-professional. It can't be just doctors alone. And I think you've taken that really on board, and you've really supported myself, especially in terms of looking at that future leadership model for Southwest London. But again, I just really want to touch on quickly, Aditi, sorry. One of the things we are looking at is that professional leadership, especially in that non-medical professional leadership, because the doctors, we know they can't do it alone, and we don't have enough of them. It's about how do we build this multi-skill support for the future future healthcare system. And I will be really speaking to yourself and Alberto in terms of some of the work you are doing in dermatology. And I just really also just want to touch quickly on what Morgray have actually spoken about. And sitting there, I could think about a lot of things that we can start looking at in Southwest London. And I know the clinical network leads are all around here. They have taken a lot of notes in terms of how we move things forward. But really more importantly, in that aspect of population health management, how do we really care for everybody within the system? And also looking at that issue that is really dear to my heart, the issue around equity of care. So again, there's so much food for thought this afternoon. And also I'm going to welcome John into our midst. Hopefully, and no doubt we're all going to support, you're going to all support us as we move this forward. And it's not just about two of us. We are all clinicians, we are all clinical leaders, really. And we are all leading the Senate. And I'm sure together we can really move that care, that efficient, wonderful system-wide care that we want to give to our local population in a safe, efficient, but that will most importantly provide that positive patient experience in Southwest London. Thank you. Over to you, John.
Thank you for that, Gloria. Or do I call you Dr. Gloria Rowland? It seems very formal around here sometimes. But look, can I just start, Andrew, by saying, wow, this is I start next week, but this is my first introduction to Southwest London. And based on Aditi's talk to us, I'm blown away, but lots of people would say that, but it was just fascinating. And actually, that sort of work didn't happen, wasn't by luck, it was by hard work, effort, collaboration, teamwork. So you haven't got those outcomes out of a lucky bag, so to speak. So congratulations to you on your work in the system over the past 3-4 years. I am mindful that you may or may not be going through a grieving process. I'm currently finishing my job in a week up here in Hull in East Yorkshire in a mental health and community trust, and I know I'm going through that transition period as I go to something new, which is incredibly exciting, but also something sad as I have to hand stuff on to somebody else. And I just wonder if you're going through that, but just to say the work that you and others have been doing, it's in absolutely safe hands. And I say that because I just want to refer back to Aditi's talk, where all the stuff that you talked about with regard to co-production, to me, health literacy, thinking about diversity, those are the kind of things that matter to me. And just to build on your comment about healthcare was all about buildings and that sort of stuff. It went through that revolutionary period. And actually, first thing to say is that people need decent kit and decent buildings to work out of to do the job. That's an absolute starter for me, for all of our clinical colleagues on the call. But how do we change the nature of conversation from the wider political sphere, which is all about building buildings, to thinking about health and wellness in the widest sense, which is what I think you've discussed. And I just flagged up the Institute of Medicine definition of quality, which I think takes in equity and cost effectiveness. So I'll be interested to talk about that value conversation going forward. So look, you I think you mentioned the number of reorganizations you've seen in the NHS. I first started working as a doctor in 1994. I think that's 26 years ago, in and around today, when I first got my temporary registration. So I've been around a lot, seen a fair bit. And what I would probably say to some of my older colleagues on the call is, in some ways, we've seen all of this reorganization before. But the other thing that I'm clear is I don't remember a nirvana in my 26 years of clinical practice. So tomorrow can only be as good as we make it today, basically. So there is reasons for optimism, but the chasing the rainbow stuff can be exhausting, but we'll just have to do our best. So I'm really looking forward to working with people going forward. Gloria, just to pick up on the fact that it's really clear that there's that strong desire to promote the work of our admin, managerial, or corporate colleagues, whatever phrase we assign to them. And what I would say is I do come from a clinical background, but I gave up long ago thinking that the only patient-centered folk who work in the NHS were those of us from a clinical background. And in many ways, I've learned and embrace the idea that our finance colleagues, our HR colleagues, IT colleagues are just as committed to doing a good job and serving the citizens when they come to work every day as we are. And actually, if we can embrace that together, I think we'll just get better. We'll get more from what we put in, basically. So I'm really looking forward to coming back to South West London. I initially lived in New Malden about 1997 when I first got married. So while I've never worked in the area, I've certainly lived in South West London. And driving through it a couple of weeks ago, I didn't have to use a sat nav to find my way around, which was reassuring because I still need a sat nav and Hull. So that's something for me to think about over the next few weeks. And I look forward to hopefully seeing more of you face to face. But I say that with a caveat as a man who's currently isolated, because he went to a conference last week for the first time in 3 years and promptly picked up a dose of COVID for himself, and I wouldn't wish that on anyone. So that's it from me, and I think, Andrew, perhaps just to hand it back to you, your baby, to close it down. So thank you very much.
We do need to wrap up because we're out of time. I think I'll be brave enough though to just allow Dagmar to say something.
Thank you very much. I will keep it very brief. I think as probably the only local authority rep at the moment on the Senate, and a really sort of passionate supporter for that clinical network right from the beginning, a huge thank you. I know how much effort it was. We were meeting evenings in Wimbledon to start with. Lots of personal effort has gone in. I think there is super camaraderie between the clinicians. I think coming together in that network, and now with the ICS, we can do a lot. Do not forget the local authorities. There is enormous talent and goodwill in local authority. It is not the dark side. I used to be a clinician. I got catapulted over. I thought I have to lick my wounds. I like it now. It is full of opportunities. People care for places and people just like you. So let's overcome some of the division and really make the best out of our new opportunity. And Muir, I will be in touch. Thank you.
Brilliant. Thank you, Dagmar. So let's draw to a close. I'm just going to say to finish, it's been a real privilege to work with you all and to support you as best I can, to provide some direction and some cloud cover at times, and I'm just incredibly proud of what we've achieved together. So thank you for everything that you've done, and thank you for what you'll continue to do. I'm excited to see what happens next. Let's close there.